Welcome to another episode of the Wealthy Podcast. I'm your host, Shauna Nyros, and today we are talking to Dr. Daryl Wile, a neurologist at Kelowna General Hospital and the visionary behind the Okanagan Movement Disorder Clinic. Today, Dr. Wile and I talk in depth about neurodegenerative disorders, Alzheimer's, dementia, and Parkinson's disease. So if you're curious about whether that loss of memory is just normal part of aging or whether it is a symptom of Alzheimer's, curious about what the symptoms of Parkinson's disease are, and what some of the steps that you can take now to avoid these diseases in the future, listen up. All right, we are back with the Wealthy Podcast. I'm so excited to be sitting here today with Dr. Daryl Wile, who is a neurologist at Kelowna General Hospital. In 2015, Dr. Wile established the Okanagan Movement Disorder Clinic at KGH to focus on a comprehensive approach to the care of patients of Parkinson's disease, an area of specialty for Dr. Wile, and other movement disorders. Dr. Wile serves as a clinical investigator with the Southern Medical Program Center for Chronic Disease Prevention and Management, that's a mouthful, and is involved heavily in teaching and mentoring medical students and residents. I first met Dr. Wile in 2021, I think, when we were developing the case to advance brain health care at Kelowna General Hospital. So Dr. Wile's vision has been instrumental in transforming care for patients living with neurodegenerative diseases such as Parkinson's, Alzheimer's, and dementia, especially those living in rural and remote communities. His passion for advancing brain health care at KGH recently inspired a $1 million gift from the Humphreys family. Welcome to the podcast,
Thank
Dr.
you.
Wile.
Thanks for having me.
Yeah, it's great for you to be here. So before we sort of get into all the goodies that I know you have, we start with an opening tradition on the Wealthy Podcast. So of course, when we talk about being wealthy in this context, it is to recognize that there are many components that make up our health and that to be healthy is wealth. And so most of the people that we have sitting in that chair have a vested interest in being wealthy. So for you, where did it start? Like, what is it? Do you have kind of like an early memory of when health or awareness of health kind of touched your life and started to inspire your curiosity to do more?
I guess so, yeah. When I was a kid growing up, my brother had inflammatory bowel disease.
Oh.
And so I guess I sort of came to understand from that you can have an illness and still at times sort of be healthy more or less. And even if it's something that doesn't have a cure that you take, for a week or a month and then it's gone, that you have to live with an illness, that your health can still be good. Which is kind of an interesting thing. And I guess maybe I've learned to understand that over time in other contexts. I would then think of my grandfather, my mother's father, who died after a number of strokes. And that showed me, I guess, how illness can affect who someone sort of is or how you can communicate and they're kind of the core of who they are as a person. So before that, to that point, I didn't really know much about neurology, brain health. So that was uncharted territory for me at the time. And so in hindsight, that you then think about what was there before and what's been lost with something sudden like a stroke. So those are two early experiences that I think have shaped how I think of health.
How old were you when that experience happened?
Well, my grandfather, when I was a student in high school kind of thing. My brother, it was all through our childhood together. So when I was kind of around the ages of 10 to 14, 15. Yeah.
And when did you kind of decide that maybe you wanted to get into medicine?
Actually, that came after quite some time. So in undergraduate training, I studied psychology, science of psychology at UBC in Vancouver. And I was interested then in experimental research and behavior and what kind of drove how people behave and motivation. So that was kind of an early experience. I didn't really know what I wanted to do. I went to graduate school after that because I really enjoyed the content of brain health and behavior and how the brain works and perception and things like that. And I ended up doing a graduate degree in auditory perception and music perception.
Wow, interesting.
At McGill, yeah. And I still found it really fascinating and interesting, and it was challenging in many ways. And I found like I didn't see a long runway for myself in a career of pure research. So
is that the path that would have led to if you'd continued?
Yeah, I was in a PhD program that was sort of like you could fork off as a master's degree or a PhD degree, and I came to realize after about a year and a half of doing that program that I should probably create a finish line at a master's degree and then move on to something else. I still really enjoyed the content and the subject matter. But it was actually partly through some of the training, because we had experimental psychology, like the Master's of Science program, alongside a clinical psychology training program. And so we did lectures along with the clinical psychology graduate students as well, including some work on positive psychology, which was sort of emerging and new back then, and the science of happiness and how people become happy. Because psychology traditionally focuses on pathology, and this is not a new idea, but at the time it was sort of semi-new. And some of the stuff we were exposed to in that led me to think about what is meaningful to me and what would be engaging for me and the kind of skills that I have, and then rethink kind of my career path. So that's part of my story.
So like basically what you're saying is that you enjoyed the content so much it caused you to reevaluate your own happiness and sense of purpose, and then you decided on a different path.
Yeah, well, I guess I was evaluating what I liked and what was not quite right for me about the path I was on, and there were some, like in many things in life, there's some good and some bad. And then, you have to have some self-awareness to unpack that. And I think that takes people a very long time. So I think it's quite normal for people growing up in school, in high school, in university, early career, to actually learn more about themselves and then feel a need to make changes. I think that's a normal process. And many people just stay put where they are, slightly unhappy or not really understanding why they don't feel fulfilled. And many people also don't have opportunities. So I have to say, like, I've been very fortunate with the opportunities that I've been able to undertake.
Yeah, it's interesting because I have a son who is heading into his third year of university in the fall, and it's quite a lot of pressure to make a commitment to, an academic path anyway that you hopefully will result in a career in something. I love that you can articulate that it's healthy and normal to pivot, change your mind.
Yeah, for the young people.
Yeah,
that's totally normal.
Yeah, not for the rest of us.
For everyone. Yeah, well, it used to be that people would have multiple careers typically, and I don't know. Things have changed a lot with the workplace and post-secondary education and what people see value in, and I'm of course far removed from that now. I'm a dinosaur, but I know people think differently about it now than they did back then when I was going through undergraduate training. But I thought you had to do that. You've got to be locked into university if you want to get any kind of job. And like I said, at the time when I was finishing my undergraduate degree, I actually didn't really know what I wanted to do. I just liked neuroscience, so I found a path forward that continued that interest. So yeah, I was very fortunate, I would say.
Yeah, and here you are. You've really followed that, interest and curiosity about neuroscience to a very specific specialty. So fast forward to today. What's your mission? What's the mission you're on? What's the purpose that's driving your work?
Yeah, so my clinical work is around creating a system of care for people with Parkinson's in the interior of BC, and specifically in the Okanagan here in Kelowna, and making sure people have access to the highest quality care with treatments, allied health, supports, and community supports, new research, and that mission is kind of dovetailed with a variety of other missions in terms of growing neurology services in the interior of BC.
What's different about practicing in the interior versus an urban center?
Yeah, I would first think from the perspective of the patients. So our patients, if you look at the Canadian Community Health Survey, for instance, are much more identified as rural than people living in major urban centers where a lot of specialist care is sort of concentrated, like in the Lower Mainland, for instance. The numbers are roughly, depending on how you define rural, something like 13% or 11% in all of BC, and then more like 35% of people in the interior. So we have a huge amount of people.
Qualify as rural.
Yeah, rural.
Yeah.
Or, I would say Kelowna is more of a smaller urban center is how I think of it. But we serve a population base that's distributed around a very large area. And people, by virtue of that, have a lot of trouble with access and travel to get care. And they may have less equity in terms of access to advanced therapies and specialized care with specific technologies or treatments that tend to be centralized in larger academic centers.
Yeah, it's certainly, the geographic area that the interior health region covers is significant. And we've heard from other clinicians and physicians that it is a unique challenge and an opportunity for those that are practicing in tertiary hospitals like KGH. So I'm going to kind of get you to unpack for our audience what are neurodegenerative diseases? Like, what are we talking about when we say Parkinson's or Alzheimer's, dementia? What exactly are those?
These are conditions that cause gradual changes in the brain over time, and we distinguish them by the types of pathology that they have within the brain and the types of symptoms that those produce. And they share some features in terms of how they originate, in terms of conceptually how they originate and the type of process it is. But they can be very different in terms of the ways that it shows up in terms of symptoms or effects on people's daily life and how they function. So the big category of neurodegenerative diseases, people would think of Alzheimer's disease and dementia. And Parkinson's disease is the second most common neurodegenerative disorder. And in BC, there's probably about a ratio of 4-1. So if you think of people with Parkinson's disease in the interior, Ministry of Health data would suggest we have approaching 3,000 people with Parkinson's disease in terms of crude estimate, and maybe 4 times that or thereabouts people living with Alzheimer's disease. They have very different needs and they have very different effects on how people function, and the treatments are also quite different between them. There are other neurodegenerative diseases as well, but those are the most recognizable or most common.
I'm curious because just in the limited exposure that I've had from working with you and working on sort of a case for advancing brain health at KGH, I seem to come across like the word neurodegenerative disease and disorders kind of used interchangeably. And I don't know, this may be just for me, like what's more correct or accurate? Like, is it a disorder or disease?
A disease as a term probably just is implying more specificity, knowing the specific cause of an illness. So a disorder is I think more invoking a process is going on that may have less kind of specific understanding around it. So if people think that there's a process at play, but maybe not yet clinched down the specific cause, then it may be termed that way as a disorder.
So they're better classified as disease. Neurodegenerative, I don't know. Is it just semantics?
So terminology is important because that's how we communicate in medicine. And the language can be confusing for patients and families, for sure. So a common one, too, that is sort of relevant to your question is people will ask about dementia, and then they'll ask about Alzheimer's disease. And for many people, they're synonymous, or they mean the same thing. But in fact, most of the time, it's more complicated. And so if we look at people with dementia, what we're saying is that there's a cognitive disorder or a disorder of brain function that would prevent them from being independent, essentially.
Oh, that's the main
so if
criteria.
If people perceive as they age that they have slipped, like they have some kind of change in their cognitive function, then we would say that is subjective cognitive decline. So they've noticed a change. We may or may not be able to measure that. So for like a mathematician, if they say there's subjective cognitive decline, I can't probably identify a limit to their mathematical calculation abilities. But if you do careful measurements and you can demonstrate that they were better and that there's been a change, then you can say that there has been a decline measurably. So if we can measure it, then we call it mild cognitive impairment. And then we would assign kind of the type or domain of cognitive function that's applicable. So for Alzheimer's disease, that's an amnestic or memory-related cognitive decline primarily. So we would say amnestic mild cognitive impairment. So more terminology.
Like amnestic, like amnesia? Like, is that the
medicine's just full of old terms like that are quite stodgy and confusing for people.
Right.
But that's what it means. There's a memory problem, and people have noticed it. And if we can measure it, we say there's mild cognitive impairment of that type. But people may have mild cognitive impairment and still be able to be independent and function.
Right.
But they've noticed something. We can see that it's there as well. Their family's noticing it, others notice it. When it comes to a point that it's impacting them to the point they can't function without supports and help, then there's sort of a threshold or a Rubicon you cross where it becomes dementia rather than mild cognitive impairment. So that's kind of what those terms are referring to.
Okay, so this is like, I'm going to go rogue here a little bit. And you can be like, this was not on the notes.
That's okay.
But I am in a phase of life, perimenopausal, and I feel like I have mild cognitive impairment.
You've noticed a change? You have subjective cognitive decline?
Is that what you're saying? Indeed. But I don't, I'm hoping it's just as a result of, okay, please.
I'm going to normalize that a bit for you as well. And this is
I feel like I'm not alone.
I'll often use this to illustrate to people as well how brains work is if you've had the experience where you go a night with very little sleep, your sleep's been interrupted, or you have a crisis, there's some issue like maybe your house is threatened by wildfires and you're not sleeping and you've got a whole bunch of things on the go. Your brain's not going to work the same in those conditions, right? So that's just normal in terms of how brains function and work. So there are these external factors that can be optimized or not, and your cognitive function can fluctuate along with that, and that can be normal. So part of what we look for is a pattern that's persistent and progressive as well. So it can be quite normal for people to have sort of cyclical fluctuations, or if people have like something occurring in life that sets them back for a while, then that can certainly impact clarity of thought. People can feel scattered. This is normal. There's an ebb and a flow like that for most people in life. And part of like brain health and brain wellness is about trying to think about, well, am I doing the things that I can do to give my brain the best conditions for it to function? And that applies to people with sort of like no brain disease and also to people with a brain disease. We just see an amplification of the effect if people have a brain disease.
Thank you. I feel better.
Yeah.
I also just think that, I think I'm not alone in saying as we get older, those episodes where you're just like, the word doesn't come, or you can't remember that guy's name that you just met 2 seconds ago, or, you read a book and you read it, but you couldn't tell anybody what it was. It just happens more often. So like, if I'm understanding you correctly, that's normal. And
that can also be normal.
Don't necessarily have Alzheimer's.
Correct.
Okay.
Correct.
So
I'll give you an example. So I know personally I'm not as good with remembering names. And the reason is sometimes I don't attend to the information. When someone says, "Hi, I'm so-and-so, nice to meet you."
Yeah.
If I haven't if I've been thinking about something else and not processing, I may forget that. So when I met Jason, I said, that happens to be my middle name. That's a mnemonic. So that's a little tool I'll remember, having met him, that his name is Jason. So you can use those sorts of things if you strategize ahead of time. But if you're not able to attend to something, you can't store it in memory. So you can have a normal functioning system, but if the file clerk is not putting the file into the folder, then you're not going to be able to find it later.
Interesting.
Yeah.
Okay, this is totally another rogue question, but since you're sitting here and I have you, have smartphones, in your opinion, or is there evidence, contributed to sort of that lack of cognitive fitness, right? That we might have had it prior, when we had to remember our schedule, for example, or remember a phone number.
Someone's phone number, or how to get from point A to point B.
Right? What did we do before there was Google Maps?
These are wonderful tools in many ways for information access and things. But I think if you consider how people use smartphones, they're also used with essentially a behavioral addiction for many people. And you can think of an analogy of something like smoking, or another habit that is temporarily going to allow you a distraction from something that's bothersome for you or disturbs you in some way. Because with a smartphone, you have access to, immediate gratification from whatever your chosen flavor is. Like if you like using an app, a social media app, where you can see people responding or things that you enjoy looking at, then you have access to that at any time. So if something's bothering you and you don't want to address it, or you don't feel you're capable of dealing with whatever that stressful stimulus is, you have a way to escape it immediately. And people don't see that with the same negative health connotation as we would smoking. Whereas, maybe 30, 40 years ago, people thought about smoking without so much of a negative connotation. And that was the smoke break. The smoke break now is the smartphone on the toilet break.
For sure. Yeah. I am a retired yoga teacher. But I would
Does one ever retire?
Probably not.
Probably not.
I'm going to try to teach you yoga while we're sitting here.
Okay. I could probably use that, actually. Posture.
But I would often lament the loss of the smoke break, not because of the smoking of the cigarettes, but what we would do when we had a smoke break, or people that smoked, would actually take a break from whatever it is that they were engaged in. And sometimes it was high stress situation, and it'd be like, I'm going to go for a smoke. And what you would do is you would literally cut yourself off from that experience and give yourself 5-10 minutes, and you would breathe. It was bad stuff. I'm not
breathe something.
Definitely not advocating breathing cigarettes, but the act of just kind of taking like a break and a breath was sometimes all you'd need to be able to go back to whatever it was that you were doing. But we don't do that now.
I think the structure of that is interesting too, because you would have a social element to it. Probably you would go and you'd chat with people or whatever, the water cooler or the smoke break chat. So I think a better approach would be normalizing like a wellness break that's more like motion, or like a walk break or whatever, something that's active, like an active break, where it's actually becomes a social thing, and encourage people that you can do that for 2 minutes or whatever, 5 minutes, 10 minutes at some point in your day if you need to take a little pause. That would probably be a healthier one.
And okay, so let's follow that then, because I've some of the folks in our office have started to do that, taking like
Very good.
walk breaks. I haven't been invited yet. I'm just saying. But like, what does that do for our brain health?
Very interesting. Actually, there's really interesting work about the effects of even like small amounts of exercise, and whether you conduct it indoor or outdoor, there's a differential effect on attention and brain function in the period immediately following. I don't have it at my fingertips, the precise studies, but so it is probably better to do that outdoors within nature than to do it on an indoor walk. And it's good to do it rather than not, than an active break.
And there is evidence that does sort of help with mental clarity, productivity, all those things that we're sort of looking to cultivate in workplace culture.
At a brain physiology level, there's evidence. So people can measure like potentials in the brain, like when, when the brain reacts to something, there's like delays and potentials you can measure. And it's measurable when you do something like that, that
Really?
It improves reactivity.
Wow.
Yeah.
All sorts of support for taking a short, like what are we talking about? Like 5, 10, 15, 20 minute, walk break.
Yes.
Yes. Okay. You heard it here, folks, from the head neurologist at Kelowna General Hospital. Go for a walk. I feel like everybody has said that lately. Just in terms of kind of going back to neurodegenerative disease, what are the risk factors for Alzheimer's, dementia, Parkinson's? What are the risk factors?
Yeah, so we would say there's modifiable and non-modifiable risk factors.
Okay.
So there's things you can change, things you can't change, in other words. And the biggest one is age. So we can't change that, at least at the moment. So as we age, the risk of developing brain disease is more and more. As we sit here, even if we're saintly and doing our daily walks, we're losing brain cells. 10,000 brain cells a day or thereabouts.
Ooh, I don't like
even
that.
if we're really saintly people. So it's a function of time in part, and we can't really change that. There probably is some benefit to exercise on gradual slowing of normal brain aging, but other risk factors for brain degenerative diseases include things like head trauma. We see stroke and vascular risk as a big contributor to brain function over time. And most people diagnosed with a neurodegenerative disorder have an overlap of a neurodegenerative disorder and the effects of stroke and cerebrovascular disease over time. And so the things that are preventive for cerebrovascular disease, stroke, and heart disease are also preventive for long-term brain health. They're effective for that.
Which is amazing because we just had Dr. Tkach recently record an episode, and he talked a lot about some of the things that people can do to help promote their, what do you call it?
Brain health?
Vascular health?
Brain vascular health, yeah.
Yes, yeah. Gosh.
Exercise, I'm sure it came up. Yeah. Sleep is good.
Yeah, don't eat eggs. I didn't like that one. But
okay.
yeah,
I think that's maybe a controversial topic.
I know.
I remember when I was in graduate school, a grad student I was working with, he was so confused because he kept seeing new publications about eggs, and he'd been eating lots of eggs, and then he had to stop, and then he was eating lots of eggs again. And so a lot of these things, it depends on what you read as well. But I'll have to educate myself on the egg.
Yeah, I think it's the yolk is the problem.
Okay, so you take the 2 shells and you kind of
you do the thing. He said eggs in a box. You can get the eggs.
You can get the
box.
carton, but what's the carton made of? Do you have microplastics?
Oh my gosh, you're killing me right now.
Yeah, so much to worry about nowadays.
Yes, but honestly, I actually feel like it's hugely valuable that we know these things, right? Because then we can. Part of what we're trying to do with these conversations is not just talk about the problem, but look at ways that we can help at least delay or even prevent if that's possible.
Yeah, I think with diet, so my wife, Erin, is a dietitian. And so
perfect.
The lesson I've heard a lot from her is rather than taking things away or not eating things, it's more about adding in the good things and eating more variety. So just a plug for intuitive eating and that as well.
Awesome. Okay, well, I don't know about that because my intuitive eating wants me to eat chips
Chocolate,
and drink wine.
That's, well, in moderation. In moderation.
Indeed, yes.
Yeah.
So we've talked a little bit about Alzheimer's, just to sort of wrap that up. How do you diagnose Alzheimer's?
Yeah, it's a clinical diagnosis, but the field is shifting. A clinical diagnosis meaning it's diagnosed based on the examination and the clinical features. We all will almost always, and it's sort of guideline-based care, that if you're receiving a diagnosis of Alzheimer's disease, you should have a brain imaging study. And partly that's for the reasons I just mentioned. So if there's a comorbid or a second additional problem of stroke, for instance, then there's different prevention strategies medically we would want to undertake for people with both of those problems than if there's no evidence of stroke or low stroke risk. So brain imaging is important. Where the field is shifting is what's called biomarker diagnosis. And in the past, this was mostly more invasive biomarkers with analysis of spinal fluid. There's now emerging research around blood tests that might be helpful in the diagnosis of Alzheimer's disease and Parkinson disease. There's also a lot to say about brain imaging and functional imaging.
Interesting. So you can actually see like degeneration on a brain scan.
What we see is accumulation of the pathologies that are particular to Alzheimer's disease or Parkinson's disease.
And is that just a fancy word of saying like characteristics, or what is pathology?
Well, yeah. So neurodegenerative diseases in general, they share some characteristics under the microscope. A lot of them include accumulation of misfolded proteins or clumps or aggregates of abnormal proteins in the brain. In Alzheimer's disease, there are some that are outside the nerve cell, what we call tangles and plaques, like amyloid plaques. And so we can image those if we can attach something to them and then look with a PET scan where they are in the brain, if they're distributed over time in different brain regions that are characteristic. That's one way of saying it looks like that pathology is there. The brain and spinal cord are also bathed in this brine of fluid, the spinal fluid, the cerebrospinal fluid. And if we sample that fluid, which is protected from the whole body system, we can sometimes see differences in the proteins that are resident in and around that brine that the brain is living in, that can similarly predict that we're going to see that kind of pathology in the brain. So in Parkinson's disease, it's a bit different because we have different types of clusters, different proteins, and they tend to cluster inside the cell. So it's harder to get something to attach to that within the cell for imaging. But there's little clusters of these proteins that can sort of migrate, and as the pathology spreads through the brain, there are ways to sort of measure that. And so those diagnostic techniques are emerging with the goal of trying to diagnose people earlier when symptoms arise, or sometimes even if they're minimally symptomatic or pre-symptomatic. Because we think if we have treatments that can slow the progression of one of these diseases or prevent it from progressing further, obviously you'd want to do that as soon as possible when you identify that it's there.
Mm, absolutely. So you talked a little bit about the difference between the pathologies of Alzheimer and Parkinson's. Parkinson's, I feel like, again, this might just be my ignorance, but it manifests in ways that are a little bit more visible. So, for example, tremors. Is that one of the ways that sort of you can identify early Parkinson's, or is that more of a progressed symptom?
Yeah, not everyone has tremor with Parkinson's disease, but it is a very visually striking thing if people develop a tremor. And often that'll be an early feature that leads them to seek care, like seek diagnosis or investigations. The other things that we see are slowness and stiffness and changes in walking. Those can sometimes be more subtle. They can also be sometimes explained away in other ways. If people notice a problem, there might be a reason that it for them is not a sign of something worrisome. And then sometimes after that, it can just take a while to access care as well if people are concerned. So that pain point between when you're worried about something and when you get assessed is one of the challenges that we face with access that we really want to improve. Then there's also, because it's a progressive disease, sometimes the features early on are quite subtle. So people can have very subtle or mild features, and only over time does it become clear that they have a specific condition.
What would those be?
The different features?
Yeah, like say
Yeah.
for Parkinson's disease.
For Parkinson's, we think about motor and non-motor, so movement and then other symptoms. And so the things people mostly refer to are going to be the movement related ones. So slowness, walking changes, stiffness in the limbs, one or more of their arms or legs, stiffness in the core muscles, or trouble with walking balance. So sometimes it shows up when people start having difficulty turning corners or falling when they're going up or down stairs, or when they're off balance, uneven ground, that sort of thing. Or people may find they're slowing down on a walk with someone they normally keep pace with, or they may find when they're swimming, they're turning in a circle because one side's not working so good.
Interesting.
Or skiing, they might find their reaction time is not as good, and they feel they're not safe to ski anymore. And is it just normal aging, or is it beyond the pale? So it's kind of like when we're talking about memory, people can notice a subjective decline in function, and then we have to see, well, can we measure that, and is it beyond the pale, or is it sort of explainable in other ways? So with Parkinson's disease, it's also a clinical diagnosis, meaning the symptoms that they have, we examine patients in detail, and then we identify if they have the typical motor signs of Parkinson's disease. And as in Alzheimer's disease, in that field, there are some emerging biomarker approaches to diagnosis that are probably going to have an impact on how we diagnose and when we diagnose people in future.
So if someone is exhibiting early signs of Parkinson's disease, or even if they have a diagnosis, like you talked about the cognitive decline with Alzheimer's, which I think most people are fairly familiar with, as kind of like the characteristic of Alzheimer's, is that memory thing. Does Parkinson's affect the brain function?
Like cognitive function?
Yeah, exactly.
Yeah. We do see that. And of course, you can have both of those conditions as well.
At the same time.
Diseases,
Right.
if you prefer.
Sure.
And so, but the types of cognitive symptoms or brain function symptoms we see in Parkinson's disease are different. Not everybody develops cognitive symptoms with Parkinson's disease, but over time, it's more likely that we'll see changes in frontal lobe function, which tends to be things like processing time, speed of reaction, judgment, multitasking. Often people will say they just have a little bit longer before they're able to contribute, for instance, in a conversation, and then they'll find by that time others have moved on and they start to feel they're withdrawn from conversation or they're excluded. So that would be kind of a characteristic description of frontal lobe dysfunction emerging. The other pattern we'd see would be the brain visual and spatial function. So sometimes people will notice something that looks like an illusion, like a shadow. They'll think there's maybe a bug or a bird, and then they look and there's nothing there. So although that can occur in a healthy brain as well, in low lighting conditions, or if you have some kind of visual problem, if it occurs repeatedly and more frequently, progressively over time, it can be a sign that the brain visual areas are getting tricked, and that the visual spatial function is changing over time. So we see sometimes one or both of those patterns in people with Parkinson's.
Wow. What I've interviewed a few people living with Parkinson's disease, and one of the characteristics I've noticed is that they speak really softly. And that's like new for them. Like they didn't used to, like they would have like this big booming voice. And then, so is that just sort of like not being sure, or is it like the muscular energy required to speak?
That is a clinical symptom. We call it hypomemia and hypophonia, the reduction in facial expression, and then the softening of the voice. So those are kind of in the middle of the body. So like stiffness in the core muscles, we see some people with an emphasis on middle of the body symptoms and signs. Other people tend to have more asymmetric, affecting one side of the body in an arm and a leg. Usually it will stay asymmetric and will stay more with an emphasis on one side, but hypophonia, the softening of speech, is pretty common. Sometimes people will also describe they get pooling of saliva, or saliva will kind of drip out the side of their mouth and things.
And that's just like a muscular delay?
Yeah, it's actually not overproduction of saliva. Typically, it's underswallowing. So
Right.
the normal automatic swallowing movements are not occurring. So sometimes just chewing gum or having a Werther's, no brands, hard candy.
It's okay. We
can,
like Werther's.
can help stimulate like swallowing that's not happening automatically and just clear that. That would be the kind of tier 1 approach of treating that problem.
So, if someone is like, I imagine there's a lot of fear around these diseases. And, we've seen very public individuals, Michael J. Fox being one of them, that has been really brave in kind of just still maintaining his public visibility, even though he clearly has been impacted by the progression of his disease. Do people delay getting care because they're afraid of the diagnosis?
Yeah, some people. That's very individual and very personal, I think. So we typically see, like we're talking about, more diagnosis as people age. So we would consider young onset Parkinson disease, depending on who you ask, before 65 or before 60. But we do see people who are diagnosed in their 30s, their 40s, even younger. And so many people are then in the workplace. They often will want to continue working because they find it meaningful and rewarding. And sometimes people struggle with when to, disclose a diagnosis to people they know, their coworkers, their boss, their employer, or just friends. And they can feel maybe a loss of, they feel maybe isolated by the diagnosis, or they feel ashamed of the diagnosis, even though it's, not their fault. But those are difficult things for people to wrestle with. And a lot of people will kind of have, a point of acceptance where they identify with it. And other people do not really to the same degree. So we see a lot of different responses to that. So that's another area where we are, grateful for supports that people can access for counseling. So for instance, Parkinson BC offers free counseling from the funds they raise for people and families to kind of grapple through these things and talk with counselors who know a lot about Parkinson disease.
Yeah, and certainly like some of the changes that people living with the disease are experiencing can be pretty difficult.
Mm-hmm.
I know that one of the attributes that people really celebrate, your patients really celebrate, and their families, about you as a physician and a healthcare provider, is that you have a level of empathy that is pretty remarkable. How much of that plays into your work, like sitting with patients and helping them navigate to the best of your ability? Obviously, it's not the scope of what you do, but you have a background in psychology. Some of the mental health challenges that I imagine are just inherent in these diagnoses.
Yeah, so firstly, I would say we take a team approach. So we look at resources and services that can complement the physician assessment, like offered through Parkinson BC, or when we're talking about voice, we're fortunate to have a speech pathologist part-time in the clinic, and speech therapy is really valuable for people with PD, Parkinson disease, people living with Parkinson disease. And physical therapy we have in our clinic part-time as well, and social work. And social work can offer supportive counseling and connect people with resources to answer questions about how they, apply for this or that or complete such and such a form. But for me personally, this is one of the things that kind of attracted me to this sub field within neurology, is because it's essentially longitudinal or long-term relationship you form with people. And so because it's so different from person to person as well, Parkinson's can be very different. You do have to get to know the patient and their family in some way, so you can understand what is meaningful to them and how the illness is impacting them and what their goals are. Because for instance, if you take tremor, we can see people coming with tremor to the clinic who really want to eliminate tremor entirely. Like that is their main goal. They feel very embarrassed in public, or we may have someone working, and let's say you're a real estate agent and you're going to close a deal and you're shaking, then it's much harder for you to succeed in your work. So some people, that's a high value treatment target. And other people will say, actually, you know what? I'm retired. I don't really mind if I'm shaking a little bit here and there. I mostly want to make sure my balance is better and that I'm not going to fall and break my hip or something like that. So two people with the same symptom can have very different perspectives on whether it's a treatment target and at what level they want to meet their treatment goal.
You mentioned, I kind of do want to get more into some of the work you're doing at the Movement Disorder Clinic, because it's really, I think, maybe it's not novel in your area of expertise, but it's certainly novel for our region and community. But I wanted to ask you about the fall thing. Is a fall sometimes the first indication that someone has Parkinson's disease?
For us, that would usually be a concerning first symptom. And it would suggest that there could be some other things to consider in the list of possible causes.
Right.
Whether that's a second problem alongside Parkinson's disease, or an atypical or a different form of neurodegenerative condition. A lot of things can look similar to Parkinson's disease, but have sort of different features. So early falls or frequent falls are worrisome for us. There are also things that lead to significant what we call morbidity in healthcare, or people get injuries. So falls and choking are worrisome to us, which is why when we identify those things are there, we want to try and attach people to fall prevention treatments and preventing choking as a risk. So that's where those allied health supports are so valuable. But sometimes people do end up seeking care after they have an injury. And it could be that they've had a progression of symptoms emerging over a long period of time leading up to that.
And they may just not have noticed.
Could be.
They're progressing.
Yeah, or maybe everyone in their families notice and they just, they have a different perspective. Or, maybe there's, like I was saying before, maybe reasons to explain away a problem. Like if someone has like a knee replacement and they feel like, oh, it's just taking longer to recover for me than expected, and they may attribute some changes that have actually been gradually progressing, maybe even preceding that when they're having symptoms. They may attribute that to a problem with arthritis, for instance, or a problem that's, like something that's fixable with a surgery. But then if you find things continue to worsen over time, it's not really consistent with that kind of process. So sometimes we see that sort of thing play out as well.
Mm-hmm. I have so many questions for you just with regards to kind of like the patient care side of things, but I want to talk about the Movement Disorder Clinic. I know you're very proud of getting that off the ground, and we've been sort of walking alongside you as a foundation as you get that going, and there's been a lot of wonderful success. But I want to talk about what it means for patients. So you talked about sort of setting goals with your patients, and so then what? Like what happens in the clinic?
Yeah, I would say, so we've been talking about how people first notice a symptom or problem that eventually will lead them to get assessment. So the first point we try to get to is establishing if we can pick apart all of the symptoms and untangle that ball of yarn and say, this is because of this is because of that. There's sometimes an element left that we can't really explain in full. Maybe we need more testing to get to the bottom of certain things. So there's an initial process where we try and establish a diagnosis or multiple kind of diagnoses, and then identify which of those we have treatments that can help. So if we believe someone has Parkinson's disease, it's often actually good news in some ways, because our treatments can be very effective in improving how their movement is and how they function. And sometimes people actually see improvement in their physical abilities and what they can do that can be remarkable for them and have a lot of impact. So they can, gain back hobbies and activities that they previously had stopped doing and things like that. In many cases, we have treatment. The first phase of treatment adjustments is getting people kind of as optimized as we can. And then because it's a progressive illness over time, we see things change. So we periodically will check in. We'll keep people in contact with our nursing team and our clinic team. and in corresponding with their primary care and their other doctors, and then try and identify and address things as they come up to the extent we can.
Okay, so when we're talking about some of these strategies to impact mobility, is it like physio kind of thing, or is it more like cognitive exercises?
Yeah, so physical therapy is really important. Often, so this is something that's an interest of mine, actually. We often will employ physical therapy as a treatment when people are sort of near falling or when they begin having falls. But early on, often people will present with hand function problems. And so I think there's probably a lot of benefit people would get from addressing those things maybe earlier. It's a limited resource. We're very fortunate to have Sierra, our physical therapist in the clinic, basically 0.4 2 days a week. And then there's other access to physical therapy in the community and other programs and things. But most people I find generally will benefit from physical therapy at some point in the course of their illness. But yeah, if we go back to your question, like in terms of cognitive or brain training exercises, it's not usually something we prescribe. We find that there's much more impact to being physically active and to exercising. And one of the things we like to identify is, are people active? What are they doing? And then are there barriers that we can try and help address to get them more active?
Yeah, I was going to actually ask you about that because I feel like I have read or heard recently that like running helps delay the progression of the disease. Have you heard this too, or is this like bro science stuff?
No. So there's many different modalities of exercise that can be helpful in different ways. So running's a great example of usually a very aerobic activity where, you're breaking a sweat, your heart rate's going up. Running, if you present with a walking and balance problem, is maybe not the best.
Right. Yeah.
choice,
but early.
Yeah. So this is the thing. So for some people, that might be a great thing. And some people we have with Parkinson disease have very mild symptoms. They're almost absent. They feel normal with treatment, or sometimes even without treatment, they can feel nearly normal, and they're able to do those things that they like to do. They may have to adjust how they exercise, but it's great. What we try and do is we find what people enjoy, and then we try and enable them to continue with that or optimize around that. But aerobic exercise is great, where people can access like programs and services in their community. That's great. But I also think, and this is kind of why we're studying this in the near future, there are a lot of people who don't have like a gym nearby or equipment to do exercise, resistance training, weights and things. And so we would really like to be able to get people to exercise in little small chunks that are realistic and achievable for them, with minimal kind of barriers and minimal need for like a gym pass or a facility or a class that's a certain time of day, that kind of thing.
So like walking.
Walking's great. It's, we try and first assess around the Canadian healthy activity guidelines for older adults. So walking would be an example of like a low, depending on how you walk, low to moderate intensity. We want to get people doing more moderate to high intensity aerobic activity, at least a little bit. And then typically take a little bite as well from resistance training or strength, and then some kind of balance activity.
Right, because the loss of muscle mass as we age would certainly play a role in some of these balance issues, and help kind of maybe mitigate the risk of falling.
Yeah, with muscle strength, you can rent it, but you can't buy it. So you have to stay active to maintain muscle strength. Yeah. And we do find, we'll often say at a simple level, it's better to have strong leg muscles and weak leg muscles if you're near falling, especially because people have sort of impairment of their righting reflexes or balancing reflexes. So if your center mass is off and you have to correct, then you need core strength to do that. And you need to be able to restabilize on your legs. So if people have poor muscle strength in their legs or their core, they're more likely to fall and injure themselves. So getting people to do that stuff at some level is great. So we try and do any little bit is good. Focusing first on what people enjoy is going to be more successful.
Maybe swimming too, because like there's not the impact.
Yeah,
the joints.
for some people, so pain can be a big barrier for people. If they have arthritis, it goes along with having age-related diseases. People tend to have more problems with pain. And so for some people, that can be a great way to get aerobic activity, even just doing exercise in water and that kind of thing,
water aerobics. So
yeah.
fun. I'm going to totally be that lady.
Jazzercise, whatever.
Yes. So
and
fun.
There's some great stuff that the community has set up around those ideas. And there's lots of neat kind of local things. There's like a boxing group, and people do like a singing group. So there's lots of ways that people stay engaged with a community of patients that they feel that they're not alone.
And certainly I think maintaining those connections would also be helpful for folks living with Parkinson's disease, just sort of feeling like they're a vital part of their community still.
Yeah, so the Parkinson Society BC and Parkinson Canada have a lot of patient support kind of work that they've put in. And so they have like a young onset Parkinson group, and they have a caregiver support group and things. So people, if they feel it's helpful for them, can engage with other people and bounce ideas and stuff like that.
Amazing. We'll try to put some of those links in our notes. So if anybody is interested in getting more information, it's in the show notes.
That's right.
I'm trying to be so cool, podcast host. Just a couple more questions before we wrap up. You're doing so great. So thanks to your work and that of your colleagues and your team, KGH is actually really fast becoming a center of excellence for brain health care, particularly where it comes to regional or rural communities. Because as you said, that the delivery of that care is very different than someone would, or than what your colleagues would be delivering in the Lower Mainland or Calgary. What is I know you have a vision for the future of care at KGH with regards to neurology and brain health. Can you share that?
Yeah. I'll first start with Parkinson's disease because you kind of hit it on the head. When you think about why would we do this here? Why would we want to have this kind of program of care here rather than have it kind of more centralized in a center where there's already a lot of expertise and research activity and resources like in the major centers? The reason has to do with the population and the nature of the illness. So these are people who I think are vulnerable to accessing care if it's too far away. And so telehealth and the ability to do video assessments has helped a lot, but it's not the only thing that we need to employ for people with Parkinson's disease. The examination is a lot more valuable in making a diagnosis than for some more kind of test-based or investigation-based conditions where it's easier to do a video call plus like a scan. Our clinical exam has a lot more value. So for us, like recognizing those needs of our population and treating that as a strength rather than a downside or a risk is kind of part of the broader vision. So we've taken that approach too with stroke care, which you probably heard about with Dr. Tkach. We have to look at the environment we're practicing in and say what's different about where we're working and how can we turn that into actually like an opportunity to demonstrate doing things differently, redefining how we provide care and how we create a service that's good for our population. Because we're not the only place in the world where people have this problem, where there's a lot of people that aren't living in major academic centers. So that's part of the broader vision. We'd really like our people living in the interior to feel like they can access comprehensive care for brain diseases, nerve and muscle diseases, neurological health at the highest level without feeling they have to go elsewhere or that they can't access it here. So that's the biggest vision. And a lot of that is just about bringing in the people and creating the teams and creating the environment where that's possible.
And I know we're slowly chipping away at that. You've really been driving that vision forward, and it's been just humbling to be part of that process for you. And for those that don't know, the KGH Foundation has been supporting the work of Dr. Wile and his teams for a number of years now, including this vision for the future. And there's more to come, but I can't share it yet. But congratulations on all you've achieved so far. I'm going to just switch gears tiny little bit. Because this is also a podcast about people and you're a person. So
thank you.
What gives you hope for the future, Daryl?
What gives me hope? So in what context?
Just in general, there's a lot to be pessimistic about, but that's not what we're about here.
Yeah, I'm continuously impressed with the positive energy coming from my colleagues in the face of a lot of barriers and obstacles. People just have such a positive attitude here about making things change and making things better. That's a huge source of inspiration for me to continue the work. That's, my colleagues in neurology and the hospital in general. It's a very nice environment to work in, a nice community of people. And the whole hospital team, the allied health team, the community supports, the patient support groups, people love living here and they want to make things as good as possible for them. So that brings me a lot of hope. Secondly, I think there are a lot of changes in neurology and in brain health care that have occurred in the last 10 years that I've been practicing. And we see momentum building with a lot of these conditions that were previously thought to be essentially a lost cause and not curable. There's progress. Progress is slow, but progress is better than none. And we've had huge advances in other areas in neuroscience as well. And we're seeing the effects build up within the neurodegenerative disorders as well. We're making headway into finding ways to slow these diseases down or reverse them or stop them.
Yeah, that is exciting. And knowing that we're all sort of marching towards, it's inevitable if age is the biggest risk factor. Mm-hmm. All of us are vulnerable until they figure that one out.
Yeah.
Which I actually heard that they did figure out. They're just not telling us.
How to reverse aging?
Yeah.
Okay.
Yeah, I feel like I heard that they cracked the code. Anyway, it's a different podcast.
Subscription service.
Yeah.
Probably.
Yeah. What areas of your health do you feel you are wealthy or abundant?
Family. My family brings me a lot of happiness. That's a lot of my inspiration and motivation comes from, wanting the best for my family and wanting also them to live in a place where they feel, if we need, then we have the access that we need to care as well. And for me, I get a lot of my energy from staying active as well and exercising. I love being outdoors, and I'm so glad I came to live and practice medicine here because it's a wonderful place to grow in that way personally. And so that's changed me a lot coming to live here. It's made me a much more active person. I think helped my own health quite a lot.
It's such a gift to live here. Mm-hmm. I totally agree. And I think that we have, part of my vision for this podcast is that we can talk about health prevention and promotion. And just by virtue of the fact that we all live in an area, community that is so rich in abundance and natural kind of beauty. And also it just seems like the people that live here want to be outside and be healthy. I think that really works in our favor.
Yeah, and it's such a fortunate thing that we have this research center, the center that I'm part of, that you named at the start, Center for Chronic Disease Prevention and Management.
Yeah, lots of words.
Where the focus is largely around partnering with researchers at our university campus that are interested in this, in health and exercise science and behavior change. And there's so much expertise here that's relevant to the types of things that we want to apply for our brain health patients. It's just a great synergy. So I'm very grateful to be able to access those colleagues as well.
Well, I think that's a perfect place to wrap up. Thank you so much for the work that you're doing in our community and for just continuing to be persistent and a pioneer for a broader vision of brain health care and Parkinson's disease care here in the interior, because we need it.
Well, thanks for asking. I'm very happy to share with you my thoughts, and I'm grateful to be part of this new project.
Yes, we are grateful for you. Thank you.
Thanks.